Hello, this is Dr. Kim Jong-il. Today, we will discuss teeth movement when using Meaw. As today is the first part on this subject, we will look at how they move when we apply tip-back activation, and how they move when we apply anterior vertical elastics, or AVE, on the anterior region. Normally, the Meaw can be applied to the mandible and the maxilla. We can use Meaw in both extraction and non-extraction treatments, and the default type of Meaw designed is flat Meaw. Meaw like these all include tip-back activation. First, we must design the Meaw. We must initially create it in an ideal arch form and then flatten it. Starting from the second loop, we apply tip-back activation by 5 degrees each. This is applicable for the third, fourth and fifth loop, ultimately resulting in a 20 degrees tip-back activation at the final loop. So the curve of SPI Meaw is applied to the upper, and the reverse curve of SPI Meaw is applied to the lower. To complete the procedure, we normally use 3 types of archwires: ideal archwire with tip-back bends, reverse curve of SPI type nitty arch wire, and Meaw with tip-back bends. In 2004, Dr. Matsui studied the biomechanics of Meaw through photoelastic study. The Meaw at this point, just like all arch wires, has tip-back activation. Here are the results. The results are analyzed. The first important aspect of tip-back activation is that the anterior and posterior direction of force depends on the location of the rotation point. In this case, in which the rotation point is in the maxilla, the rotation point would be between the first and second premolars. On the other hand, where would the ideal arch be? Between the maxillary first and second molars. In cases of nitty archwire, it would be between the maxillary lateral incisor and the canine. Comparing Meaw with nitty and ideal arch wire, it can be seen that a weak force is applied in the case of Meaw. We must remember that, in cases of Meaw, the rotation point is between the maxillary first and second premolars, which alters the pattern of movement of the anterior and posterior teeth. In other words, the maxillary anterior teeth will move forward, while the posterior teeth will move backward. Where would be the rotation point in the mandible? As mentioned previously, between the mandibular canine and the first premolar. Because it is between the canine and the first premolar, we can see that there is space created even in non-extraction cases. We should remember that in cases of Meaw, the rotation point is normally located in the premolar region. If the rotation point is in the molar region, there would be less movement in the molar region and more movement in the anterior region. If the rotation point is in the anterior region, there would be less movement in the anterior region and more movement in the molar region. In cases of Meaw, however, the rotation point is in the premolar region. When the rotation point is in the premolar region, both the anterior and posterior teeth could move simultaneously. We must inspect the mandibular and maxillary teeth separately. Depending on the pattern of malocclusion, the pattern of movement of the teeth, especially the maxillary front teeth, premolars and molars may change. In other words, the maxillary anterior teeth may experience linguoversion as they extrude, or in other cases, incline labially as they are intruded. This is the same for the molars. We need to be aware of the various patterns of teeth movement, because it directly affects our ability to diagnose what types of teeth movement in the front teeth, premolars and molars would be best, by looking at the causal factors of malocclusion. We can choose between mesial movement, distal movement, extrusion, and intrusion. In some cases, it could be best for the mandibular molar region to be intruded and move mesially, or be intruded and move posteriorly. In other cases, it could be better for it to extrude, upright, and move mesially. In other cases, extrusion, uprighting, and posterior movement of the mandibular molars may be the best option. To understand teeth movement, we must be able to think step by step. This would be a case of MEAW with tip-back activation without the use of elastics. In this case, how would the teeth move? When we use MEAW, the anterior teeth experience dramatic change. When this happens, what we must inspect with great caution is how the maxillary anterior, premolar and molar regions move, and then how the mandibular anterior, premolar and molar regions move. Let us review. Where are the rotation points? In the maxilla, it is between the first and second premolars, and in the mandible, between the canine and the second premolar. Then how would the front teeth move? They will experience intrusion and labioversion. What would happen to the premolar region? Extrusion. What about the molars? They would be uprighted distally and intruded. In such cases, we adjust the occlusion using elastics depending on the type of malocclusion. In the finishing stage, the most important factors are the maxillary and mandibular canine relationships. Therefore, the maxillary canine should be located between the mandibular canine and the first premolar. The canine relationship must be class 1. And what would happen to the premolar? The mandibular premolar would have to be located between the maxillary canine and the first premolar. We use the term retrusive control for this. We would need to relocate the premolar. I personally use the magic triangle, and in the finishing stages, you must apply elastics taking both of these two aspects into consideration. Let us discuss open bite. In conventional orthodontics, what were considered as the causes of open bite? We were taught that it was the overruption of the molars and the underruption of the front teeth. If the molars are overrupted, they would be intruded, and the front teeth would be extruded. Many use mini-screws to intrude the molars, and mini-plates to intrude the maxillary molars. Elastics can be used in the anterior region for extrusion. Would this be everything? Many people use at least 8 to 10 elastics. In MEAW, the elastics are applied from the first loop to the first loop. Why would this be the case? The first etiological factor of MEAW is extrusion of the maxillary molars. The second is flat UOP. Flat UOP is when the maxillary molars are overrupted, or when the maxillary front teeth are underrupted. The next factor is steep POP. If we want to proceed with treatment, the maxillary molars must be intruded. The flat UOP must be steepened. The steepening process includes the extrusion of the maxillary front teeth and the intrusion on the molars. The steep POP must be flattened. The whole mandibular dentition must be uprighted. Therefore, the occlusal plane is considered a crucial factor when treating with MEAW. When we apply elastics in the finishing stages, we must first look at the midline, and then the canine kai and overjet. In this case, we can identify a class 1 canine relationship after the leveling process. Thus, we can complete the treatment by using anterior vertical elastics from the first loop to the first loop. How do we want the teeth to move in cases of open bite? The maxillary and mandibular anterior region should extrude and fit occlusally. We use the term AVE, or anterior vertical elastics, when we apply MEAW. When we apply elastics on the maxillary first loop and mandibular first loop, we use the term anterior vertical elastics, or up and down elastics. In cases without MEAW, it would be applying elastics on the maxillary or mandibular, canine or the maxillary lateral incisor. What causes teeth movement like this? This is when we only use anterior vertical elastics. The areas with the elastics applied will extrude. The molars will move slightly distally. The maxillary and mandibular front teeth will be extruded, and the premolars and molars will move slightly distally. In cases such as this, which should be stronger the force of the wire, or the elastics? When tip-back activation is applied, this is how it looks after engaging. The force of the elastics must be stronger in order to move the teeth like we want. In cases of MEAW, we normally use 3/16-inch 6-ounce rubber bands for anterior vertical elastics. How do the teeth move when we use MEAW with anterior vertical elastics? Again, we must apply elastics on from the first loop to the first loop. At one point, the occlusion is adjusted. We must check each individual region. We must be aware of how the maxillary and mandibular front teeth, premolars, and molars move. MEAW and AVE are applied. The MEAW would include tip-back activation. Then we use the anterior vertical elastics. Because the force of the elastics is stronger, the front teeth extrude and experience linguversion when the anterior vertical elastics. What happens to the molars? The molars are intruded, uprighted, and moved distally. We need to remind ourselves of the etiological factors of open bite. They are the extrusion of the maxillary molars, flat UOP and steep POP. How should we design the treatment? The maxillary molars must be intruded. When we apply MEAW and the elastics, the maxillary molars are intruded. The strategy of treatment includes a steep UOP. What does the steep UOP imply? The extrusion of the maxillary front teeth and the intrusion on the maxillary molars. The maxillary molars should be intruded and the POP flattened. What does the flat POP imply? It implies the intrusion on the mandibular molars and the extrusion of the mandibular premolars. When we use MEAW with anterior vertical elastics, the mandibular premolars are extruded and uprighted, and the mandibular molars are intruded and uprighted. MEAW and anterior vertical elastics are good for open bite treatment, because we can control the etiologic factors of the open bite. That is the reason why many orthodontists consider MEAW as a magic technique for the open bite treatment. In this lecture, we discussed the patterns of teeth movement when we use MEAW, especially those with tip-back activation and anterior vertical elastics. Thank you for watching.